Hello and welcome to our session on the Integrated Health Service Plan for 2016 to 2019. I want to welcome and thank you all for joining us this morning. My name is Jeff Lowe and I'm the board chair here at the Southwest Local Health Integration Network. We know that the LHIN, along with all of you, have important responsibilities in transforming healthcare across the province. We need a more integrated system. We've spoken about this together, exclusively, inclusively for the last number of years. It helps create a better healthcare system for all of us. We know too that we need to better organize and connect services to create an integrated, sustainable, and comprehensive system. Puts the needs of the patients and our clients first. And we need to intentionally, not by accident, work together to align services, systems, and processes across the Southwest LHIN. You know, I've been board chair here now for 5 years plus, and more often than not, it's been my experience working with the governors and working alongside of our CEO, the LHIN executives, and all of you, that the answers we're looking for to improve healthcare actually exist already in the creativity and the innovation of the work you all do every day. And we're going to need that commitment and that leadership and that focus as we move into the last part of 2016, 17, and beyond. We all have a role to play. And we think that our Integrated Health Service Plan, the one that's been created for 2016 to 19 with a ton of input from all of you as well, has built on the accomplishments of previous plans and brought us closer together and brought our visions closer as we move forward. We passed the IHSP at our board meeting in January 2019, and it certainly is helpful as we make decisions going ahead in how to dispense the $2.5 billion, give or take, that the Southwest LHIN funds in our geography. We need to work together with our stakeholders, we know that, our sector groups, our networks, the governors, and the people who use the system if we're going to make sure our health system is actually working for people across the Southwest. Under legislation, we have accountability to meet the challenges in our health system for the benefit of those we serve. The IHSP to us is one of the most important tools in our tool chest. It's important to people in our communities, and it's focused on making a difference to improve health care for all of them. We look forward to working with you and trustees to achieve the IHSP objectives in developing a healthier tomorrow. So I think I'll leave my comments at that for now and turn it over to our CEO, Mike Barrett. Mike?
Thanks very much, Jeff. Thanks very much to all of you for joining us today. This is, as Jeff said, our second of 2 webcasts. We held our first on Wednesday night. The content is identical. The questions will obviously be different in the second half, but the content is the same. And we did 2 simply to ensure that for health service provider governors, boards of directors, that they had an opportunity to do this outside of work hours. We've got a large number of participants today from a real variety of different organizations, from all of our health service provider organizations that we currently fund, but lots of others that are joining us today from other organizations like public health, primary care. So it's great to see a real diversity of people around the virtual table here. In terms of our webcast today, we have a number of objectives. One is to set out the goals of the healthcare system and our health and direction for all of our health service providers over the next 3 years. Provide an overview of our IHSP, as Jeff said. Provide a short update on the Patients First discussion paper, and then answer any questions that you may have around the IHSP. Our intent is that Jeff and I will talk probably for about 30 minutes, and then we'll leave the last half hour of the webcast for questions. And there is a question box in the bottom left-hand corner that you'll be able to, if you have questions as we go or questions that you want to provide to us, they'll appear in that question box, and Jeff and I will do our best to answer those questions. And I'll just give a bit of a heads up that this webcast was originally advertised as an overview of our IHSP, but also an overview of the Patients First work that's going on across the province, really, and with the discussion paper. As you know, with the Patients First work, the discussion paper was released in December. Consultation period took place in January and February. Those consultations have now been concluded, and I can talk as we go into the question period about some of the feedback that we received. The ministry also received that feedback. And what I'm saying about the change from how the webcast was advertised to how we're going to present today, we are going to spend more of our time on the IHSP. And that's simply because at this stage for the patient's first discussion paper, the government has received the feedback from a number of different organizations across the province. We're now in a bit of a quiet time. The quiet time where the government has the opportunity to create the legislation that will be required to make the structural changes that are proposed within the discussion paper. So we're respecting that the government will take that time, take all the input that's been provided to them, and as I said, it is a quiet period now until the legislation comes out, and at that time we'll continue to have further engagement, as we always do here at the Southwest LHIN, to make sure that people are aware and up to speed on what's going on with us, but also provincially as well. So in the healthcare system, we've seen improvements in many areas, but there is more to do. Over the last decade, we've seen improvements in the amount of interprofessional care that's provided in family health care and primary care. We know that 94% of the population now have a regular family physician, or a regular family healthcare provider, I should say. Emergency room wait times have improved despite substantial increases in volumes, and we know that 92% of home and community care clients say that their experience has been good, very good, or excellent. In 2012, the Ministry of Health and Long-Term Care released its first action plan for healthcare. It was Minister Deb Matthews at that time. It was refreshed in February of 2015, and from there has really been the foundation upon which the patient's first discussion paper was put into place back in December of 2015. There are 4 areas in the action plan for healthcare back in February of 2015 around access, connecting, informing, and protecting. Here's a chronology of some of those steps that I identified already. The original action plan back in January 2012. The PSS regulatory amendments and policy implementation. These guidelines came out in July of 2014, and we're now working through that with the ministry and with our partners in the home and community support sectors to create one sector through common intake, standardized assessments, coordination of care, and consistent client experience. And then, as I said, in February 2015, the Minister Eric Hoskins released the updated Patients First Action Plan. May 2015, we had the roadmap to strengthen home and community care, which was the response from the ministry to Gail Donner's expert panel report on strengthening home and community care. And that roadmap has 10 points within it that talk about areas of strengthening home and community care. And then finally is the discussion paper, and it was released, as I've said a couple times already, in December 2015. The consultations are completed, and we're now in a time when we're looking to government to pull together the legislative changes that are required to make the structural changes that are needed within the system to actually advance those directions in the paper. So in the discussion paper, there was 4 areas of focus. One is an expanded role for LHINs, and I'm sure all of you, as most of you being health service providers and active in the healthcare system, know what is in the discussion paper. A considerable increase in the responsibilities for all LHINs across the province. But what the discussion paper is trying to address, and the directions that are contained there, is creating timely access and better integration of primary care. I said earlier that 94% of the population has access to a family physician, but we know that 56% of the population has challenges seeing their physician, or seeing their primary care provider same day or next day. We also know there's challenges in terms of the consistency and accessibility of home and community care across the province. And if you're sitting in the minister's chair, the premier's chair, they want to know that there is consistency across the home and community care sectors in terms of the types of care that's provided to the population of Ontario. And then finally was the last link, or last component of the discussion paper, was a stronger link to population and public health, with the suggestion that the funding and accountability for public health be transferred over to the LHIN system. I'll emphasize again that these are directions that were up for discussion, and we're now looking to see what steps the government will take to advance those directions. So you step back and look at how do you ensure that you have a healthy population, And again, all of you that work within the healthcare system know that it goes beyond the health service providers that are part of the LHIN system. It goes into housing, education, income, genetics, all kinds of different components that actually influence how healthy an individual will be within society and how healthy the population is. Since the LHINs have started back in 2006, we have spent time focusing on specific populations that do have greater needs for many of the healthcare resources and services that are provided within the system. Some of those priority populations include the indigenous populations, francophone populations, people living with or at risk of chronic disease or with mental health and addiction issues, or those that are frail or have medically complex conditions or disabilities. This diagram here is intended to capture our integrated health service plan. And it's probably a real challenge to capture what's within the integrated health service plan in one diagram, because we cover the system, we have a large healthcare system, obviously, lots of different providers. Within the Southwest LHIN, we have a large geography. But at the center of this is the person-centered care. So it circles around the person, the patient, the client, the resident, and our aim is to improve the population health, improve the person experience, and get better value for money. The green circle around the people on the inside are our IHSP priorities. So I'll talk to each of those 7 as we go through the presentation today, and identify what some of the work that we're moving forward with to ensure that we've got the right steps in place and right action plans in place to advance the system. The blue semicircle at the bottom are some of our implementation strategies. So we need to ensure we've got always have quality improvement and innovation at the front and foremost. How do we use e-health and technology? How do we ensure health equity for all the services that are provided? So those again are a fundamental component of our healthcare system. And at the top is an integrated health system for all. So that's our goal, is that we've got to have a better integrated system across all sectors, all providers, and across the entire geography of the Southwest LHIN. People always ask Jeff and I and others here at LHIN, how do you know that you're actually making a positive impact on the system? So at our system goals, which I've addressed previously in the previous diagram, the 3 system goals, it's the IHI, the Institute for Healthcare Improvement triple aim, improving population health and health outcomes, improving the experience of care, and improving value for money. And we have 4 big dot outcomes that are captured within our integrated health service plan for the next 3 years. We're going to be measuring self-reported health status to see where if that's changing as we go through this 3-year period. Are people getting faster access to the appropriate care? Are people satisfied with the care that was provided? So it's that patient experience. And then ensuring that we get value realized by reducing hospital visits in days. And this looks very simple, but it's not so simple, because within each of those big dot outcomes, we have 26 system level measures that are aligned under each of our 7 IHSP priorities. So I'm going to take a few minutes and just talk about our 7 priorities. To do them justice, it probably would take a lot longer, but we want to make sure, Jeff and I, that you have an opportunity for questions and comments. So I'll go quickly through the 7 that are in front of us today. So the first one, optimized healthcare for people and caregivers living at home, in long-term care, and other community settings. So we've identified a number of action plans that we'd like to advance to further this first priority. Maybe before I do, I'll just talk about Chelsea. Chelsea is a participant at Participation Lodge. Has always been a great part of our system here, and I had the chance to talk to Chelsea 2 weeks ago at the opening of the new Participation House building here in London on Adelaide Street. Still smiling, still friendly and happy, and I think in large part, or in good part, to the great work that happens at Participation House. So, the action plan. So we're going to identify strategies to advance the home and community care roadmap, the 10-point roadmap that was that's been produced by the government. We want to enhance the availability and access of adult day programs and its related transportation, transition care clinics, assisted living, and redeveloped long-term care homes. And then ensuring that we've got coordinated care across all populations that receive supports from different ministries and different organizations. We know that many of you as health service providers, the LHIN funding that you receive is only a portion of the funding that makes up your entire budget. You may receive funding from MCSS, MCYS, Ministry of Community and Social Services, Ministry of Children and Youth Services, from other organizations, United Way, and from your fundraised dollars. With each of our priorities, we're identifying how we will know that we've been successful. So with this first one, we want to ensure faster access to care provided by personal support workers and nursing in the community, and fewer people waiting in the hospital for care in the community. Number 2 is our focus on primary care. We've done a lot of work, even though that primary care is not part of our funded organizations, with the exception of community health centers. We've done a tremendous amount of work with our primary care partners over the last number of years. And we're lucky to have 3 primary care physician leads led by Dr. Gord Schachter helping us with that work. So we have a number of actions around primary care, ensuring that we've got steps in place to deal with same-day, next-day access for primary health care, with the caveat, fully recognizing that not everyone needs same-day, next-day access to the primary care physician, but when they do, it should be available to the population. We want to make sure we've got enough capacity to meet the needs of all populations. In some of the directions in the patient's first discussion paper, talk about doing greater human resources planning. So if you have physicians retiring from certain communities, how do we ensure that we're planning properly to ensure that the capacity is there to support the population in the future? So how will we know we've been successful? Faster access to primary care when you are sick, fewer visits to the emergency department for conditions that are better managed in primary care, and more people seeing their primary care provider following discharge from hospital. Number 3, we have a significant focus on helping people prevent and manage their chronic conditions. We've done a lot of work, as all of you probably know, around health links, some great success starting here in Perth and rolling out to North Grey Bruce, South Grey Bruce, London Middlesex, and Oxford and Elgin also coming on board as well. We want to ensure that we've got standardized care pathways and quality-based procedures for certain chronic conditions. We want to ensure culturally safe chronic disease care for the Aboriginal and Francophone populations. And we also want to ensure we've got the right electronic tools to help people deal with their chronic conditions. We'll be measuring this by looking at improved transitions of care following a hospital stay and fewer people needing to be hospitalized for chronic conditions. Our 4th priority in our integrated health service plan is assisting those living with mental health and addiction issues. We've done a lot of work with our partners, and I should have said this at the start, and Jeff said it as well. The work that we're doing is work that sometimes we play a coordination role, obviously a funding role, but it's through the great work of all of you as providers that allow us to advance the system and make the system change that's necessary. So, on the mental health and addictions priority, we want to increase the availability and access to crisis services, supportive housing, peer support services, which we're doing quite a bit of work on right now. Again, ensuring we've got standardized services, care pathways, tools for assessment, screening and experience of care, ensuring that we've got the right tools in place to allow providers to provide the care that's required, looking at what capacity is required within the system for those living with moderate mental illness. And we want to build on some of the other work that we've done around French mental health and addiction services system program for the Francophone population. In this priority, we'll be looking to determine how we've been successful by having fewer people returning to the emergency department due to better connections to community supports, and fewer people needing to be hospitalized for mental health conditions, and finally, fast access to mental health care in the community. 5th, we want to ensure that people have timely access to hospital-based care at the LHIN-wide level, the multi-community level, so within a smaller geography of the LHIN, and also at the local level. We've done, again, a great deal of work with our partners on clinical services planning, made some tremendous progress on stroke care, vision care, endoscopy, perinatal care. We have our perinatal network, which is doing great work bringing providers across the system together, not only in that case, not only in our LHIN, but in the Erie St. Clair LHIN as well. We've made some significant changes which have not always been easy. Our board has led those decisions and had the fortitude to go forward and make them. It does require shifting of resources, which is always challenging as we go through that process as well. And we've had great support from the Ministry of Health and Long-Term Care as we make some of these system changes, and I'm thinking particularly around stroke. So we have lots of other opportunities ahead of us, spreading best practice for antimicrobial stewardship across hospitals, ensuring we've got the right steps in place to care for those people that may be in hospital now, but could be supported in community, and particularly chronic mechanical ventilation, those patients that use that mechanical ventilation. So how do we know we've been successful? Faster access to care in emergency departments, faster access to surgical and diagnostic procedures, and improved cost alignment to the provincial standard. So health system funding reform is obviously a big component of the work that's going on here, and has significant ramifications and issues for our hospital partners. Our sixth priority is dealing with rehab, so ensuring that we've got a rehabilitative approach across the care continuum. We've done a lot of work here in working with our provincial leadership around the rehab group provincially, but making sure that we've got a rehabilitative care plan and a rehabilitative performance dashboard. So we've got a number of steps underway, and how will we know that we've been successful? We'll have more people able to access rehab services to maximize recovery. And finally, our seventh and final priority is helping those people living with life-limiting illnesses and their families at the center of hospice and palliative care. And I said on the Wednesday webcast that hospice, residential hospice and palliative care, end-of-life care has certainly taken a higher profile, certainly in the last couple of years, and since the LHIN has been here the last 10. And we've got some great examples of work that's going on, not only in residential hospice with our partners in Owen Sound, with Grey Bruce, with Secura House in Woodstock, and here in London Middlesex with St. Joseph's. So we've got great partners there. We intend to do more. The provincial budget did announce new resources coming for palliative care, and we've done some, the partner in the network, the palliative care network, have ensured that we've looked at what capacity is needed across our LHIN, and if new resources are coming, where those resources should be dedicated to. Again, we want to make sure that any approach is culturally sensitive, and that we plan and implement an Aboriginal approach to hospice palliative care as well. So how will we know we've been successful? More people with palliative care needs being supported at home. So those are our 7 priorities. And if you bring back the diagram of that captures our entire integrated health service plan, there are very strong linkages to the directions that are outlined in the patient's first discussion paper. So stronger links to population and public health, which is, I talked about the triple aim. An integrated health system for all. Within the discussion paper, it talks about subregions, and I'll talk briefly about the subregions in just a minute. Again, more accessible and consistent home and community care. We have a considerable focus on that within our integrated health service plan. And then primary care planning and performance is a significant priority for us within the IHSP. So the message that Jeff and I are trying to deliver is that the IHSP is well aligned with the directions that are captured within the discussion paper, and we believe will set us in a positive position for advancing health system work over the next 3 years. So again, we want to ensure that we're working with our partners to achieve that stronger patient-centered healthcare system. And as I said earlier, we believe that our IHSP is well aligned with the content that's outlined in the discussion paper. I'll emphasize again that it is a discussion paper, and we are looking for the government now to bring forward those legislative changes that are required that address some of the structural changes that are identified in the discussion paper. The consultation is complete for the Patients First discussion paper. We had 5 regional sessions across our geography in Owen Sound, Mitchell, Ingersoll, London, St. Thomas. Great feedback from both public and providers. I can talk about some of the themes as we get into the question and answer period. Our feedback from the consultation is posted online, so if you go onto our website under Patients First, you'll be able to see the comments that were received. And we made sure that the consultation, the comments that we received were sent off to the ministry, so they're helping. The comments that you provided at our sessions are helping to inform the ministry as they move forward in the development of the legislative changes. The discussion paper talks about LHIN subregions, and I think this is a key component of the discussion paper. And it talks about better integration at the local level, and that better integration can happen between primary care. I think there's significant opportunity there for better connections and collaboration between primary care and other parts of the system. Better connections with home and community care and other parts of the system as well. And all of our partners working together within a sub-region. And we've started to embark on some work here internally in the Southwest LHIN to say, what would those sub-regions look like? How would we actually move some of this conversation forward? Again, we're respecting the government's wishes during this quiet time as during legislative development, but we hope to be moving forward with some of this work in the not too distant future. The map that's in front of you are the 5 sub-regions that we've identified here in the Southwest LHIN. 1 is Grey Bruce, 2 is here in Perth, 3 is Oxford, 4 is Elgin, and 5 is London Middlesex. And right now, Norfolk County, we're relying on our partners in the Hamilton, Niagara, Halton, Brantland to undertake some of the planning there. But I want to be very clear that these hard and fast boundaries around these planning areas are not what patients experience for the most part. So we need to ensure that even though we're planning in these 5 subregions, there's still patients that travel back and forth between these subregions across the province. London hospitals certainly provide regional-based services to a wider geography across our LHIN. So with that, we've done a quick overview of our Integrated Health Service Plan priorities. Talked briefly about some of the Patients First discussion paper. And at this time, Jeff and I would be more than happy to answer any questions that you may have. I'll remind you that on your webcast screen in the bottom left-hand corner, there's a Q&A box that allows you to type in a question that you may have for on anything that Jeff and I have talked about, or any of the work that we're doing here at the Southwest LHIN. Maybe I'll start with, as the questions are just starting, the question I get asked most is, Mike, when is the legislation coming? That answer is at the discretion of government. So we'll rely on the Ministry of Health and Long-Term Care and the Government of Ontario to do its work to ensure that the legislation is put into place. But the timing of that is at the discretion of the government, and we'll certainly respect that, and we'll look forward to it when it does come. Again, I'll remind you of any questions that you may have. Please don't be shy. The group on Wednesday night certainly wasn't shy with lots of questions, and Jeff and I are happy to answer any of those, and using that Q&A box that's in the corner of your webcast screen. Maybe one question that we were asked on Wednesday night was, what's the role of governance in all this work? And I'll add my bit, Jeff, before you start. I really commend our Southwest LHIN board. They've taken the role of governance seriously in terms of the conversations we're having with providers. Because often the conversation with our health service providers, it's different at an administrative level than it may be at the governance level. And Jeff and his colleagues have done a lot of work around that issue.
And to that point, Mike, I've had nothing but great experiences working with all of my fellow trustees and the health service providers over the past 5 years, and certainly this last year has been no exception. I certainly see as we go forward, that work is going to become even more integrated, more collaborative. Interestingly enough, I've already had a couple of boards reach out to start the discussion as to how we might be more effective, how we might be more integrated, what other opportunities there are going to exist at the governance level when we do get into a new transitioned part of healthcare in the Southwest. It would certainly be our intention as a LHIN board to work with all of you. And certainly in the sub-regions, I think that's going to be critically important, that there be a common level of understanding among trustees so that we can effectively work alongside of and provide the governance structure required in the health service providers to make things successful. So as I said tonight, I think a lot of the prep work, if you will, that's been going on among boards and trustees in conjunction with our board, and you've been very kind to invite us to a lot of your meetings. It's been a bit of a rehearsal. We've gotten to know each other now. I think we're comfortable with each other now. And so I think the work is really going to ramp up, and I'm frankly looking forward to it. I think trustees have a great role to play.
Great, thanks, Jeff. And we can see on our screen, you probably see the same thing, that multiple attendees are typing, so that's good. And we have a number of questions coming in now. The first one from Stephen Townsend: how is the leadership of the sub-region being determined? This is a great question. I'll preface everything that I'm saying today that my comments are based on the discussion paper, not on trying to get ahead of what the legislation may contain. But we have had conversations, as I said, internally, also with some other health system leaders across our LHIN to talk about how is that leadership going to be determined at the sub-region. There's lots of questions. If you had a sub-region table, how is that membership determined? Is it done by everyone being at the table? That can be maybe possible in some of the smaller sub-regions like Oxford and Elgin. Much more difficult in other areas where the number of providers is greater. So we've had conversations about, do you have a representative agency? So you have one agency from one sector representing the table, from hospitals, one from mental health and addictions. So these are questions that still need to be determined, but we're actively looking at what those answers will be. So we haven't got to the answers yet, but it's been a big part of our discussion over the last 6 weeks or so since the consultation period has ended, and hopefully we'll be in a better position to start actively engage partners around what that sub-regional leadership will look like. Question from Robert Furno: is there one sub-region which is more challenged than another, and therefore should receive more attention within this upcoming plan? I don't think at all that there's one sub-region that's more challenged than another, but Jeff and I can tell you that every sub-region is different. And in some places the integration and collaboration between partners is better than others. It's more structured than in others. And then in other places you have other factors coming into play around numbers of providers, population, geography. All those factors come into play when we're trying to establish what type of structure you have in place at the sub-regional level. So I'm giving you more questions than I am answers, but these are the questions that we've been talking about quite a bit. And once we start moving forward with some of this work, as legislation is revealed, we'll be actively engaging partners. And as I said off the top, I think the intent of this webcast was to have more of this dialogue, but at this point in time, we're in a bit of a quiet period, and we're respecting that, and we'll have lots of opportunity for conversation after that. Guest number 9, will you please speak about prevention and health promotion? We didn't see any focus in your presentation. So again, this prevention and health promotion, we certainly rely on our public health unit partners that's their one of their significant roles, focused on that population health component. But prevention and health promotion is a big part of what we do here as well. So I didn't speak to it, but you'll see in our priorities around self-management, ensuring that tools are in place for our health service providers to use self-management components. Also in chronic disease, it is about prevention, it is about health promotion, and how can we help providers or how can we help the population, I should say, by ensuring our providers are well connected and have the right tools in place to care for those people that with chronic disease. Question from CMHA Elgin. What specific strategies are planned for moving forward toward improved transition from hospital to community services? The one that I'll speak to, and it's not so much a mental health example, but one that we've spent quite a bit of time on is those people living in hospital, in ICU with mechanical ventilation needs. So in the past, typically these patients, many of them young males, have been living in the ICU. That's not where they want to live, it's not where they should live. And through some great partnerships between some of our community organizations, and I mentioned Participation House already, we've been able to transition these patients from hospital into community. So it's one example of, I think it's taken everyone to rethink about how they do their work. Participation House taking on a higher acuity person that they serve. Hospitals trusting that community support service agencies can actually take on that care. And it's taken a whole raft of professionals in between to make that transition possible. On the mental health front, though, we also need to ensure that we've got proper transition from hospital to community. And this has been a challenge. I think we're making great progress. In London, we have the Mental Health Crisis Center, which has allowed us to, CMHA Middlesex, to provide the care that's required for people that don't necessarily need health care, but need supports to help them live with their mental health issues. And I should ask Jeff if he wants to, he can nudge me if you want to.
I'll be the first to let you know.
Thanks. Next question is from the Here in Perth Healthcare Alliance. Understanding that we are in a quiet period while legislative changes occur, but in the work that is going on within the LHIN, what is the communication plan for that work? Yeah, this creates a challenge for us because I think the government wants to ensure that they have the opportunity to create the legislation based on the consultation that they received from the consultation period without organizations like the LHIN or a hospital or any of the associations that many of your organizations are part of, without those organizations getting ahead of the conversation. And we have to respect that. It does take time for legislation to be put in place. As you can only imagine, the number of pieces of legislation that would be needed to be changed from this type of structural change is significant. So we're respecting that. We're trying to continue to advance the work that we can, and we've talked a bit about the sub-regions. That sub-region work should be going on with or without the patient's first discussion paper. We need to ensure closer integration. We need to continue to ensure we're working more closely with primary care. So those will continue, and our communication has been, we're probably dialed it back a bit, to be truthful, but I think at this point in time, it's necessary to respect the work that the government's undertaking.
I think to that point as well, Mike, this is part of the communication process, what we're doing today. Realizing I'm sure people would have liked a whole lot more answers on the legislation side of things, and as Mike has iterated and reiterated, that's just not material that we have access to right now. But certainly I'm comfortable in the understanding that there is not going to be a haphazard communications plan, but rather a fully thought out communications plan, which will be rolled out in conjunction with all health service providers.
Great. Guess number 9. Is it like Agent 99 or?
I think so. Anonymous.
One LHIN in particular is forcing hospital leave for community engagement. This does not appear appropriate. What is the Southwest LHIN position on this? I'm not exactly sure the reference there, maybe I think our partners in the Toronto Central LHIN have seen a much larger role for hospital leadership in some of this work around sub-region work. That's certainly not our perspective. You know, the way the LHIN has worked over the last 10 years and how we continue to work is about integration amongst partners. How do we ensure that we have all partners coming to the table and feel like they have a voice around the table as well? It's no secret that hospitals may have, you know, larger organizations, more resources available to them, which may in some cases make it easier for them to participate in these conversations. Our intent is to leverage those as much as possible, but I can tell you that a standing principle for us is that we need to make sure that the providers are working together and everyone has a voice at the table. Next question is Naresh Singh. I talked to Naresh in Park Hill after our board meeting in April. South of the border, there seems to be a rapid evolution in approaches to deliver care. Are there any particular learnings that we're able to consider for some of our needs here in Ontario, in particular southwestern Ontario? Leveraging of technology to support home and community-based care. So there's no question, you know that there's been a number of, or you may not know, there's been a number of initiatives from the Ontario Telehealth Network looking at technology within the home to better support people with their home and community care. So there are opportunities there, and it is being addressed provincially as well. We've done a great deal of work here in the Southwest LHIN as well. I'm sure many of you have heard about eShift. That's been leveraged by our partners at the Southwest CCAC, doing great work there, using technology to really increase the capacity of their staff that are providing care and their contracted health service providers that are within the community. The other piece is, you talked about south of the border, and there's been lots of conversation in the sub-regions and what they look like. You may have heard about accountable care organizations where it's one organization within the sub-region. I'll stop right there and say that that's not the intent, that's not what's proposed in the discussion paper, but we do look at other parts, other jurisdictions. Commissioning organizations in Australia look at the NHS system of care there. So we are looking at other geographies, and I think in Ontario sometimes we're short-sighted in a way that we're big enough that we can kind of function on our own, but we should be looking outside of our boundaries to make sure that we're making good decisions about what the system could look like. Next question, Robert Furneaux. How will best practices within the Southwest LHIN be leveraged to drive progress and success of the new plan? Robert, I think it can be applicable across all sectors, all geography. I mentioned briefly about our quality improvement processes, and that needs to be integral to everything that we do. And so best practices can be around clinical best practice, it can be about patient experience, it can be about quality improvement initiatives. So we do indeed use best practices to advance the initiatives that we have within the Southwest LHIN. A criticism, I think, sometimes of LHINs is that we may not be aware of or not leveraging best practices that are happening in other parts of the province. I don't necessarily agree with that. I think we do a good job across LHINs to understand what's going on in other LHINs and other geographies. But I think we could certainly do better to make sure that we're not duplicating something or creating something on our own here that could lead to unnecessary work within the system. So again, I'll ask you to, if you have any comments or questions, use that question and answer box in the lower left corner of your screen. And Jeff and I would be happy to answer any questions that you may have around our presentation. Okay, so the next question is from Stephen Townsend. Stephen, you've been busy here. I think this is your third question now. So this is good. We like the feedback. How will the revision to the CCAC management and reporting structure affect the plan rollout and their role in sub-region leadership discussion? So it's clear that the discussion paper outlined a direction that the government was wanted to hear back from the public on. That consultation has now taken place, and we're waiting here in the Southwest LHIN, and we work closely with our CCAC partners. We work closely with them to ensure that whatever happens in terms of the legislation that will be coming, that will be properly aligned and coordinated to make that change happen. But again, we are waiting for clear direction, not just the discussions or the directions that were in the discussion paper, but we're waiting for clear direction before we start to advance that conversation into tactical planning or implementation planning. So you can see that our folks here have asked you if you have any more questions in the question box. Maybe I'll just add, Jeff and I have both referenced this, is that I think there's lots more discussion to come. I've talked probably too much about the legislation, but that'll help define the directions that we'll need to take moving forward. And as you know, it's always been our practice, either through interactions like this, through a webcast, or through face-to-face engagement, which we do a lot of here in the Southwest LHIN. There will always be opportunities for you to engage in not only with Jeff and I, but with any of our board members, any of our team here in the Southwest LHIN. At our board meetings, we always have, I shouldn't say always, every second month, we have a community engagement session following our sessions. Our next board meeting is in Bayfield next Tuesday. There's not a community engagement session there, but our following one, which is in Port Elgin, is that right? Port Elgin, we have the opportunity to answer questions there. So in the question box, you can see the website link for our Patients First work, which talks about which provides the summary of the feedback that we receive from the consultation process. Okay, with nothing further, I'll pass it back to Jeff, and again, thank everyone for their participation.
Thanks, Mike. I thank all of you for taking the time this morning to join us on this discussion on Patients First, as well as the Integrated Health Service Plan. Certainly, I would hope that all trustees that are on the phone will make it their business to ensure that the IHSP is on the agenda at your board meetings, that it's at least in mind as you make your decisions going into 2016-17. This was rather an inclusive document. It included a tremendous amount of input from the public and from all of you, and it really only works when everyone at least keeps it in mind and on the table and being discussed. Clearly there's a lot more to come. Everyone's now waiting for the shoe to drop, if you will, on the legislation side of things. But in my experience working with the health service providers, to the extent that I do, but certainly with the trustees, there's a tremendous amount of passion and focus here in the Southwest. And I believe it's going to be a break tomorrow for healthcare in Ontario generally, and Southwest specifically, as we move into the time ahead. So again, thank you for your time and attendance this morning. The websites are posted that you can see there with for Patients First, and for questions or comments you might have. We would appreciate you sending those through to us if they possibly come to mind, either now or after the fact, so we can factor them into discussions and conversations going forward. So having said that, have a good day, have a good Friday the 13th, and have a good weekend.